You are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, this is today's case study. After being involved in the incessant use of the upper limb, a 25-year-old avid volleyball player had his right shoulder joint dislocated. On reaching the physician's office, he indicated that the shoulder joint is the frequently most dislocated joint we have in the human body, and he of course put in writing the complaints by way of the signs and symptoms the patient told him. Now this is the case study we have before us. Now the first question that I want to ask is that why did the clinician, from the anatomical basis, made the remark that the shoulder joint is the frequently most dislocated joint we have in the human body? My friends, your answer is that the reason is simple. If you look at the architecture, if you look at the organization of the shoulder joint, you will see that the head of the humerus, that rounded head of the humerus, is larger compared to, of course, the glenoid cavity provided on the scapula. Now, these two are supposed to form that joint. And because the head is larger than the cavity that is going to dwell in, by way of the articulation, it is not so strong. It is not so, let me put it this way, that it is not so perfect, to ensure that, of course, the head of the humerus continuously stays, in what we call the glenoid cavity of the scapula. That is the point. So, because of the shallow nature of the glenoid cavity, but the larger head of the humerus, that's the reason why the shoulder joint continues to remain the frequently dislocated joint that we have in the human body. Now, thankfully, God saw it coming that yes, it is likely that due to some activities involving the upper limb, incessant use of it could result in that kind of dislocation. And that is why God placed something in there at the rim of the glenoid cavity, something that we call the glenoid labrum, so that it can further deepen the articular surface of the glenoid cavity of the scapula. My friends, even with that, the shoulder joint continues to be the frequently dislocated joint that we have in the human body. That's the point I want you to become aware of. Now, question number 2. In writing, the doctor also indicated that this patient actually had an anterior dislocation of the shoulder joint. Understand that the shoulder joint can otherwise be called the glenohumeral joint. So why is it that it often involves, by way of the dislocations, we often see the anterior dislocation, not posterior, not lateral? Why is it most likely the anterior dislocation? And my friends, your answer is simple. It's due to a little bit deficiency in what we call the capsule of the shoulder joint that we see in the anterior aspect compared to the remaining aspect of the shoulder joint. That's the point. Now, one thing that we understand is that by way of maintaining stability to any joint, the active stability, one of the things that we know is, of course, the capsule of the joint. Now this capsule of the joint, it goes all around where the joint is. But what we see is that comparatively, the thickness, it is very, minimal compared, in the anterior aspect compared to the remaining size of the shoulder joint. And that is why the shoulder joint dislocations, more than 95% of the cases, frequently you see that it will be an anterior dislocation of the shoulder joint. Now, the third question for us is that what will be, yes, some of the complications that may be associated with, of course, dislocation of the shoulder joint, in this case the right shoulder joint. What will be some of the complications? Now, whenever you have a shoulder joint, the tendency that there will be recurrent dislocation of the shoulder joint is high. Okay, so one of the complications that will be associated with that, there will be that kind of, recurrent dislocation of the shoulder joint, first of all. Now, the other complication is that there may be that kind of injury to what we call the rotator cuff muscles. Yes, I've done some videos regarding the rotator cuff muscle, the steering muscles of the shoulder joint. Yes, we talk about the six muscles, the supraspinatus muscle, the infraspinatus muscle, the teres minor, and of course the subscapularis muscle. These muscles, okay, there could be injury to, of course, these muscles. As far as shoulder joint dislocation is concerned, there could be avulsion, okay, for the point that they have attachment to, of course, either the greater tubercle, okay, by way of the supraspinatus, infraspinatus, teres minor, okay, and of course also on what we call the lesser tubercle of the humerus by way of the subscapularis muscle. And so when this shoulder joint dislocates, there's that tendency that these muscles may be injured, even they may lose their attachment on what we call, the bone. The other complication that can arise from this is that there could be something we call glenolateral tear. Okay, so the glenoidal labrum that we find over there, there could be tear of it. I told you that the articular surface on what we call the glenoid cavity is further deepened by what we call the glenoid labrum. And so whenever there's that kind of, shoulder joint dislocation, there's that likelihood that this fibrocartilaginous structure that we find over here, which deepens the articular surface of what we call the glenoid labrum, could get, torn. But my friends, other things that may be associated with this is, of course, there may be some kind of neurological complications. And by saying that, what it means is that there may be other neurovascular structures. So, for instance, there may be, the axillary nerve getting injured, okay, at the level of the armpit because of the shoulder dislocation. Not only that, even of course the radial nerve. So, some of these things could also get injured in there. But my friend, also vascular injuries are also possible. There may be some other blood vessels which could be injured, okay, in this regard. Okay, for instance, if you talk about the ascending branch of what we call the anterior circumflex humeral artery, you could be injured in this regard, and there may be some, things in there. And my friends, that is why the next question for you is that if someone presents with a shoulder joint dislocation, what are the, clinical features that we will see? There may be bruises over there, there may be swelling over there, okay, and there will of course be loss of mobility, either entirely or there may be limited movement at the level of the shoulder joint, especially movement by way of abduction. Yes, there will be difficulty, extremely. Not only that, even of course lateral rotation will be extremely difficult, as well as of course extension, okay, of the upper limb at the shoulder joint. These are important classic things that of course one may experience whenever there's of course dislocation at the shoulder joint. So then, my friends, what will be the attending clinician's first management process, okay, to initiate? My friends, your answer is that we first have to, because of the pain that the patient is experiencing over there, there will be the need, okay, to of course manage the pain, giving some kind of painkillers, okay, to of course reduce the pain at the site of the dislocation. And then after that, we have to ensure that of course we reduce the dislocation, ensure that we bring, okay, surgically we have to bring back this shoulder joint to its original location, okay, and of course we have to even ensure that we give some kind of support, okay, by way of immobilization, either by way of splint or what have you, to ensure that of course we reduce, okay, the chances of movement at the shoulder joint, all ensuring that of course we minimize further injury, okay, further pain, and of course facilitate healing or repair, so to speak, of this dislocated joint, and of course the associated injuries at the area. Okay, so these are the things that I want you to become aware of. Okay, I believe you find this case study very helpful. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.